Michael, it is such a joy to be able to moderate this session with you. I have watched you and listened to so many of your presentations, and we're so grateful that you would join us as a fireside chat keynote speaker for our spotlights for our symposium. It was really hard to narrow down questions because you are such the guru and you know so much, and to pull those out. So we've narrowed them down from 10 to 5, and maybe if we can get through 3, I'll be happy because I know you'll have a lot to say. So we'll do what we have time for, and we will be grateful for what you can share with us. So the first question we'd like to pose to you is, a lot of students and professionals were at some point really terrified and concerned of this new online environment, not just of COVID, but of having to use new tools and learn something in really kind of an anxious state of mind. What has it been like, the experience of practicing and teaching telemedicine in this fire drill of COVID?
Well, it's a fireside chat, it's a fire drill, it's California, oh my goodness, feeling the heat. It has been an adventure to me, actually. You know, we take so for granted all of the ways that we do what we do until the apple cart gets upset. And it was really about 5 years ago that I began to have my personal apple cart upset, and I started to use these technologies to connect with people and to explore what was possible. And one of the things that I realized was that people freak out about change, and they freak out about anything that alters the comfort that they have, the confidence that they bring to their role, particularly as a healthcare professional, but as a mom and as a father and as a teacher. All of us are going through so much in this wildfire drill. And so the main challenge is to gather people's attention, to invite them in, to settle them down, and to let the technologies do what they do best, which is to disappear, so that the communication and the relationship can happen in some ways better than it does in real life.
Could you, in follow-up to this same question, tell a little bit of the story of your open forums that you did in the spring, how you the opportunity to use both didactics about telemedicine and provide a little bit of the modeling and experience that you've had?
Yeah, it's really, it was quite a moment, right? We all were confronted by high velocity change and challenges to everything we thought we knew how to do. And I picked up the phone pretty quickly and started looking inside the networks for some mechanism by which we might be able to offer impact. We all saw what was coming to some of the hot zones, but we also, especially in conversations with Jennifer Valentine, we also recognized that even where there wasn't a huge challenge with very, very sick people overloading hospitals, there was an enormous set of challenges in every town, every village, every city, every clinical environment that was being confronted by how do they do what they do? How do they bring value to the people they're dedicated to doing so for, without placing themselves or the people they're caring for at risk? And so that it was pretty easy to see all of a sudden when we sheltered in place in California that there was a big challenge and a set of ideas that we've developed that might be useful. So Jennifer and I jumped on the phone. We started scheming for ways to try and distill both the sort of knowledge and informational elements of what makes this work, with some of my own sort of preference for experiential and transformative stuff. I mean, the kind of interesting thing is it's not rocket surgery to talk to other people. It's just learning to do so inside of a new frame. And in order to get people connected, it takes banging your way through some of the technology anxiety and frustrations that occur. And so I knew that I wanted to provide a list of pearls and some other vantage points to roll into an interaction, but I mostly was interested in putting myself and my partners in crime, partners in fire, in relationship to all of those people for a period of time. There's in the 1960s, a fellow by the name of Marshall McLuhan, a great sort of media communications and philosophy guy, wrote a book called The Media is, no, it wasn't, the book's title wasn't The Media is the Message, but the trope that came out of most of his work was The Media is the Message. He was looking at television in the 1960s and 70s as it blasted into our society and had just like seismic change because of television. And that was when it was like 4 channels and a little hanger stuck into the top of the thing, right? So he was looking at the medium itself as having a substantial impact. He was not looking at the content. He was looking at the experience that people have now that they're sitting on their couch eating Cheetos and watching endless hours of terrible television. So for me, what I wanted to do was I wanted to have plenty to talk about in these educational encounters. But I wanted the medium itself to have an impact on the people who were gathered together to talk about what they were going through in relationship to transforming their practice. And the way we set it up, because Jennifer was very patient with me, was that we laid out some solid educational objectives. But mostly I was given the freedom to kind of work the room, to explore the people and connect them to each other, to bring them out to involve themselves in conversation, communication with me, and to help them to decompress, destimulate their anxieties about doing something that seems so different, but that we've been doing since we've been babies, is connecting with each other.
Well, you're definitely gifted in this. Another question is an extension of this first question too. COVID's given people an experiential learning opportunity they wouldn't have had in multiple ways. And you mentioned the pearls. What are the takeaways from this experience? Rather than just the challenges or negatives, what are the takeaways?
I tell you what, well, why don't you serve it up on a silver platter to me? You've got a list of some of those pearls that you and Jennifer gathered. Why don't you toss them out to me one at a time, and I'll see if I can't walk them out of the park.
So, as I had listened to your different presentations, you did a number of things around setting the stage and letting the technology disappear. Help us with those pearls.
Yeah, totally. When you begin a video conference and you're inviting somebody to connect with you to do a functional task, you have an objective, you have an agenda. This is a palliative care encounter between a person living with serious illness and one of or more of their of the team members. You can presume that everyone's a little bit freaked out by the whole idea of seeing a nurse or seeing a doctor or seeing anybody through technology. People have their own stuff around, I'm terrible at managing these things. And they get particularly worked up when they can't quite make the gizmo do what it's supposed to do, right? And so when we begin, and there's a quote from the sort of setting the stage came from one of our guest faculty, Brooke Colton from UCSF, who's been doing telemedicine almost or about as long as I have in the UCSF program. And her offering was that, you really need to take responsibility for creating the environment in which you're going to work. When we talk about that in the hospital or the bedside setting, we talk about sitting down. We talk about making sure that everyone relevant for the conversation be within visual appearance to each other. We talk about being on the same level and even dropping down a little bit lower sometimes to meet the person in the bed, or elevating the bed to try to bring that in. We try to manage what we can. The hospital's a crazy place. Sometimes there's noise and in and outs and everything else, but we try and take responsibility for as much of that scene, that stage, as needed. And she talked about being like a movie director. And so when I enter into a conversation with somebody by video, I speak right to the medium that we're working with. I goof around with them. I ask them, what's that thing in the background? One of the things that I usually do right off the bat is when they're sort of jiggling around and holding their device and everything else, I get them to set it down. I mean, how are you going to listen to me when I'm doing this? That's crazy, right? So I have them set down their device and free up their hands, not just for my own visual experience or theirs, but to give it enough room to where they can just actually be in the space that we create, right? And I deal with their anxieties and their concerns until we get it all done. Sometimes it's like, 3-5 seconds, and they've done it before, they know how to do it, they've settled down. Sometimes they've got a big bright light behind them and I can only see a black silhouette of their face. We fix that. We do all that stuff beforehand. We find out who else is hiding in the wings outside the frame, right? Maybe their angry spouse is sitting right over there. I want to know about that person. Who's in the room? Who are they to you? What's going on? Is everybody settled in? Maybe we can bring them together, or maybe you haven't sat that close to each other for a long time. We'll work that all out. And then I introduce myself and I say, let's now begin. Let's begin this conversation. And that sort of is like going, action. And all of a sudden, the disbelief is suspended. All that anxiety sort of settles away. And there we are, just connecting person to person through the video medium. So that's what I mean by setting the stage, but then beginning in a very deliberate way to do the thing itself and let that technology disappear.
Along that same line, talking about seeking permission to engage, share a little bit about that, and then follow up to those settings and permission. How would you encourage faculty to use this medium in an online type course?
Interesting. Well, first, in thinking about consent, I want to highlight one of my other guest faculty, also from UCSF, the good Dr. Mike Rabo. And he really drew our attention in our session to the sort of leveling quality of this technology. I have a way of introducing myself to people. I say, hey, listen, we don't take care of any patients. We only take care of people. And that makes sense when you're talking to somebody who's sitting on their couch in their home, in their fuzzy slippers with their cat on their lap, right? It doesn't actually make sense when you've ushered them through a 30 or 40 minute process with a clipboard shoved in their face, a waiting room, And then they've ushered into this clinical little box without windows and some diagram of the sinuses on the wall with all these fascinating little things like tongue depressors and cotton tip applicators and blood pressure cuffs and otoscopes and all that stuff. They're in this room. They are a patient. They become a patient. In fact, it works most efficiently if they become a patient, and that we hide behind our white coat and our stethoscope to become a doctor, because we assume these very flimsy descriptions of what we are, these identities, and that makes for more efficiency. Then people come and they bring you your problems, you give them their solutions, and off they go to the next station in this industrially designed clinical experience. But when you're dealing with people in their home, that's what they are. They're people. And that actually, in palliative care, is sort of the critically necessary balancing of power, the power dynamic. I happen to be wearing a suit top or a blazer today as a way of sort of assuming the identity of a austere academic teacher. But in truth, I don't really dress up so much anymore. I just kind of come as I am. So, you know, I bring myself as I am and introduce myself as a person, a father, a husband, a son, and then I have a set of skills. I bring a set of experience and skills and a willingness to lean in where others tend to lean back, right? And so this leveling of that power dynamic is got a lot of interesting manifestations. Mike talked about it really beautifully in his section in the course.
It reminds me of one.
Second part of that. What was the second part of that question?
You know what? Before I get to the second part of that question, I think I want to stay with this part of the question, because there were a couple of things that I've heard you talk about, and it has to do with power differential and it has to do with space. And that is the leaning in and the moving out. And my favorite, the Post-it note and where to look. So if you could talk a little bit about that.
The Post-it note. Which one?
The Post-it note near the camera. The Post-it note near the camera.
Oh, it says screaming is not necessary or yelling is not necessary. Yeah, no. I have one that says calm is service, like, and a few other things too. Some of which some passwords on the wall and such. No, I think that what we do within the frame of this space is a world of creativity. The thing that we take for granted in a clinic is the impact of that box, that context, that examination room, or that hospital room and hospital bedside. That has a huge impact on how everybody feels, how they see themselves, what they think they're there for, the whole agenda. And similarly, being on video conference, it actually has its impact as well. We just have this lovely little square, this little window into the world of what's going on over on the other side. So if I want to know more, if I want to reach beyond the square, I have to ask for permission. They've given me permission to show up by setting up the appointment and sitting there and getting the stage set and then starting the encounter. But everything that's outside the frame, they show me by consent. Is that a dog that I heard? Can you carry the device out to show me the garden that you said was so important to you? I heard a person in the background. Who are they? Where do you keep your medicines? And how big of a wheelbarrow do you have them in? What do you have in your refrigerator? Would you mind? I'm just kind of funny that way. I like to look in people's refrigerators. So, I mean, people talk about home visits as being these really enriched experiences that you walk into the room and you see and you smell and you sometimes taste what's going on in the space, and you can pick up all of this information. But the truth is you're doing that as a home invader. You're not doing that with consent for all those layers of information. And it's very intimidating when a physician or a social worker or even a nurse walks into a home environment, despite how welcoming people are. We are a big impact. We're a big presence. And
Yeah.
we're not as tuned into that as they absolutely are. So by doing this, by sending a link in an email and a click and a little bit of fumbling around to get it right, all of a sudden we're really on an equal playing field with these folks. And it has both an invitation for intimacy that happens much faster than through all of the other sort of social primate behavior defined by the environment of the exam room or the office practice or the hospital room. It's embracing the square, it's embracing the frame, and inviting it to be acknowledged by both parties. That allows for people to relax and to decide for themselves, do they trust you enough to tell you what's true or to help them discover what's true for them.
This experience that you describe and the consideration that you have for people will lead me to this second question that I was originally thinking about. In online teaching, spent a lot of time in listening to people talk about how to do online teaching. In all of that, these ideas really haven't bubbled to the surface. So what might you suggest to faculty, perhaps around palliative care education, in teaching this telehealth online?
Yeah, I think the biggest part of it is getting everybody to turn on their cameras, acknowledging all the individuals in the space, acknowledging the technology, and then inviting playfully people to engage. In fact, when I have a group of 25 or 40 people that I'm teaching this way, I can keep them more engaged than I could if I had 40 people in a classroom. When I've spoken and made presentations to 30 or 40 people in a classroom, I can't track but a couple of actual attention spans, right? There's usually a couple of people who are able to catch my attention with their attention, and I focus my attention on presenting more or less to them. In this environment, it levels everybody into an equivalent little square, and I can poke around and look around. Now, what people will do with synchronous video educational experiences these days is they try to pretend it's like a teleconference where you turn it on and then you're on your phone, or you go get some Cheetos, or you make another cup of coffee, or you deal with whatever's around, you do your charts, you sign your papers and all that kind of stuff, and you maybe catch a whiff of the content. Yeah. Or you maybe, look at the PowerPoint presentation afterwards and pick up some of the content. But when you're talking about the medium being the message, you really do need everybody to pay attention. And you really do need people to participate. And you do need people to be reflective. And you can do that by poking and prodding and teasing and playing with all the people in the space. It almost doesn't matter when you're teaching telemedicine. It almost doesn't matter the content. They may hear, the technology disappears or some other such, beautiful pearl and remember that. But what they really get is an experience of like, oh yeah, it's actually working right now. Of course, it will work if I can relax and become curious and explore what's possible. So that's kind of, I guess, for teachers, don't let people sit around with their cameras off. You know what they're doing. If they do, they're just goofing around. They're just distracted. primates. You've got to hold their attention, draw them in, and bring them into participating. Otherwise, you can just assign them things they can do asynchronously. But when it comes time to this precious time that we give to the Zoom, and we all know how, or video conferencing, we all know how exhausting it can be to stack them one after the other. The reason why is because they do ask you to stay attentive. They do have you both listening and observed by others. You have to deal with your image, what you're bringing into the space. And just like in a classroom, kids just, people or students will just kind of lean back in their chair. They're like this, and they don't realize they have such a substantial impact on the whole environment, right? And we don't have time to tell, doctor this to sit up in their chair, get off of their phone, stop eating Cheetos or whatever it is that we have to do. But when we have them in a nice little frame and we've invited them to be responsible for showing up into it, people get the experience. I mean, we did a series of, I think it was 6 sessions with 75 to 100 and whatever people, and some people came back for more, and they didn't know why they came back, but the feedback I got later was they were getting something in the process that was enhancing their ability to go at this new frontier that was being thrust upon them in their practices. And the feedback was good that way, that being called out to be a participant in this new medium, the medium itself actually teaches you how to use it. Actually, one of the things that's quite extraordinary about this and quite superior to the educational process of learning how to interact with people in clinical settings as medical students, residents, and all the way through early career doctors is that you never get a chance to see what you're bringing into the space. But all these video conference platforms have a little square, and you may not like it very much. It may feel awkward or uncomfortable, but there you are continuously getting feedback about who and what you are and what you're bringing. And for me, it's an enormous tool for presence. Like, I can't fake it because I'm stuck looking at my own puss.
It is about presence and the experience of presence, both in others' presence and in your own. Let's look at another question. And it is in your teaching. It's a little bit of this extension of what we've talked about. There's persistent themes. And moving from teaching and thinking a little bit about research is where I'd like to go. There is clearly a need for rigorous research to define outcomes and to demonstrate the quality of telehealth empirically. What are some of the top questions that you think researchers and students, one of the joys of this conference is we have several students that are presenting their work, and it's just fabulous. And I think, what is it that you would share with students and other researchers that are important questions around what we need to look at for telehealth?
I think the main issues that come to mind for me are equity and access. I sort of trust the process to drive quality where access and capacity are available. Palliative care, depending on how it's defined and depending on how each model is constructed, at least in our model, we have a doctor, a nurse, a social worker, a chaplain, a community health worker, a care coordinator, all working together in that sort of classically defined interdisciplinary team. In those circumstances, palliative care is a practice setting that is not the only part of the care structure for people, but is, and I don't like the word saying it's an extra layer of support, it's a necessary and parallel layer of support. Because we're not the only element, resolution is to define itself as 100% technology enabled in the pandemic. And what we've discovered is that that really works. For this kind of a palliative care team constructed in this way, working in concert with specialists, oncologists, primary care providers, home health agencies, urgent care centers, emergency rooms, we haven't given up our ability to deliver value a little bit by using video conferencing. Now, that's not going to be the same if you're an oncology program. An oncology program needs to define where and when and how they use telemedicine to reduce the burden on folks, to limit to shift it towards a more person-centered oncology practice by allowing people to have some of their evaluations, some of their routine follow-up, some of their surveillance, in concert with all their labs and imaging and everything else, have some of that work done by video conferencing. Each practice setting, primary care practices are doing a lot of health maintenance and chronic disease management through video conferencing that they had never done before. But a bit less, they've restored a bunch of their sort of urgent episodic care to physical face-to-face kind of encounters. Part of it is defined by the physical exam, like when do you get, right? Part of it is designed by how deeply they've drunk the Kool-Aid. What we realize is that people who are really committed to using telemedicine are using it for stroke, they're using it for dermatology, they're using it for behavioral medicine, they're using it for psychiatry, they're using it for palliative care, they're using it for urgent care within some really rigorously defined categories of need. And that place, what we don't know is where those edges are. Like, and I think that's a really rich, area for research. Right now, I think the most interesting area of research for palliative care is just phenomenologically. Like, we have just seen probably the most radical transformation of healthcare delivery in the modern era as quickly as possible. This implementation of telemedicine-based care has been enormous. And there's going to be a whole spectrum of how people and programs respond to that. Some just cannot wait to grab a hold of that pendulum and swing right back to the status quo. And some, like us, on the other end of the spectrum, are hopped off the pendulum at its biggest swing, and we're not going back, right? And watching that occur and looking at the gains that can be made by holding on to some of what we've learned, I think the phenomenology of this experience needs to be tracked exquisitely well, so that the quality-based research can be layered on to that going forward.
Do you think that research is going to be important? This isn't one of the questions, but do you think that research is going to be important to support funding?
Yeah, I do. I think that what we can see in the palliative care space, since this is a palliative care gathering, is that our ability to take some great ideas that are 25, 30 years old by some pioneering and extremely insightful forefathers and mothers of the field, in order to translate that into 70% of American hospitals of beds greater than 150 having palliative care programs of some sort, and creating the circumstances where a burned out country doctor like me can build out and innovation into the space, and that the California State University, with the help of the Shiley family, can generate an Institute of Palliative Care to start teaching and building capacity and access around the country. That's all been sort of patiently and accretively developed over these 25 years. Over these last few years, we're watching that really accelerate, and perhaps palliative care not as an extra layer of support, if you happen to be lucky or privileged, but as a necessary layer of support for people with serious illness, is starting to seem like a realistic wish or a goal. I mean, for me personally, I don't have the patience to be an academic researcher. Honestly, I don't have the patience to generate a data set to move towards meeting the needs that are so apparent to me. That makes me a pretty good community-based kind of action figure.
Well, and we each have our place. We each have our role, and you're in the midst of it. And there's others who I'm sure are listening or thinking, I could research this, and this would support that. You mentioned
I would be using their research for sure,
right,
to leverage the change that's right in front of me, and I have been doing so for my whole career. Is appreciating and surfing on the waves of information that my trusted professional colleagues are generating. So yeah.
A theme or a facet of this discussion in telemedicine, and I'm kind of asking a little bit off the top of my head, because you mentioned about interprofessional teams. And I think telemedicine and being able to bring in interprofessional teams with telemedicine has such opportunity for palliative care and is being used in palliative care. So I'm wondering if you could share a little bit about maybe your experience with that or your thoughts on that.
Oh my gosh. This is the whole reason I built this thing, is that I struggled for years and years building out a robust and complete team. It was endless efforts to try and gather the data to make the case and ask for more money and more budget and everything else. And after all those years, I had barely a quarter of a team, which meant that myself and my social worker were having to be the chaplain. We're having to be the nurse. We're having to be the administrator, the data analyst, the blah, 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 blah. Right? And so for years, I struggled in the absence of having that whole team, which I know to be incredibly important for sustainability, not to mention for quality. I can't see around the corners, but if we surround a person 360 degrees with other people who bring different sets of information and experience, well, we can see the opportunities for moving things forward, delivering value to people that we can't. And I don't have to try and think like another well-trained professional. I can just talk to them. So that was the whole basis, really, of why I built it. It was probably my third go round with burnout. And I knew that the answer was team. And so that's why we built Resolution Care.
Thank you. Thank you for sharing about
that.
And
just as it relates to these gizmos, I'll tell you a little story. Like when March 19th came around in California, we were doing about 40% of our work by video conferencing. About 170 people under care and a really beautiful team of people doing that care. But mostly they were driving around, they were going and knocking on doors, invading houses and eating cookies and spending a lot of time hugging people and bringing them tissues and feeling very, feeling their agency in service, right? But on March 19th, it all changed. And the next day we went from 40% to 100% telehealth supported care. And many of my staff members were like, well, how long is this going to last? When are we going to go back? They get it, the whole coronavirus thing. We obviously don't want to take risks for ourselves or for the people we care for,
Right.
so we're going to do this if we have to. And so 3 kinds of domains of thing were apparent. One was it was clear that the people we cared for and their families didn't feel a decrease in our capacity to meet their needs. In fact, some of the late adopters, the people that never wanted to do it, have become subsequently the best enthusiasts for using video conferencing. We bought a bunch of gizmos. We worked hard to get the people that we were using at first by telephone to interact with over to video. Now we're about 95% of everything we do by video. And a number of things happened. The people we care for got what they needed. The organization experienced about 30 to 40% more efficiency, because not only were they not driving around, but these encounters that occur within this box happen in a more concentrated way because it's magic. I don't know, because it works that way. And so that was good for the organization. We've actually increased our census substantially without overburdening our team. And that's good for the organization.
Yeah.
And then over the first 3 months, my beloved colleagues on our interdisciplinary teams were like, fussing and fretting, and I miss it, and I don't know how to feel good about the work that I do if I can't hug these people. But actually, over the last 4 months, they've had more oxygen to take care of their families. They're 100% working from their homes, and they've stopped asking about when do we go back. They've adapted to a new frame for their work in which they are feeling satisfied. They are feeling like their professionalism, their ability to provide service and care for people is received, and they're getting enough feedback to feel really good about that. And they're homeschooling their children, and they're dealing with their own anxieties about this crazy world we live in.
It sounds like a bit of a gift, if I could go that direction.
Yeah, it's tricky. It's a tricky time in life to be thinking about the advantages of what we've had to face together as a society. There's tons of people who don't have access to palliative care. There's tons of people in the grave or in the urn as a result of the pandemic. It is an opportunity for us, though, to use these technologies to create access and capacity.
You were at the forefront before we needed it. And
before it was cool.
Before it was cool. But there were many people that weren't, and there's a lot of faculty that aren't. And there are a lot of faculty that are. I don't mean to be disrespectful, but I know in my world of teaching nursing education, there's a lot to quickly teach our students. So the question is not just about nurses, but social workers, PAs, allied health professionals. They're all going out into the workplace 6 months, a year, whenever they graduate. And literally they're being launched into this environment, often without the educational background in telehealth. What would be helpful for them to know about doing telemedicine before they leave their pre-professional education? And or what can campus faculty do to prepare these future clinicians besides play this tape?
Well, play the tape and put me in the room, put me in the game, coach. I mean, I'd like to have this conversation very specifically and in real time with the future of our healthcare workforce. I wouldn't underestimate their scrappy, resourceful, and contemporary attention to this. They're probably all Zooming with their friends, having happy hours, and interacting with their family members at a distance and coping with the isolation using these technologies in a way that's teaching them. And in fact, particularly over these last 7 or 8 months, it's been really pretty satisfying to watch how much easier it is to get
Mm-hmm.
people up and running, the people we care for and their families,
Mm-hmm.
than it was actually 6 months. So some of that work is being done by the muscular forces of the pandemic. They get it, that they better have some attention to gaining some skills and doing it. And some will say, no, I'll never want to do that kind of work. And others say, I would never want to do any other kind of work. And
Mm-hmm.
most of us be somewhere in between. You know, I'm an outlier because I'm giving all of my attention, all my creative energy, all of my scrappy, startup-y kind of energy towards really developing and defining and setting the tone for the best possible palliative care delivered this way. Other people are going to work on the best possible palliative care delivered in other ways, but Resolution Care and Michael Fratkin will be all in on this because we recognize it's important, and we hope to have the opportunity to talk with medical students and social work students and nursing students and chaplaincy students. This educational component is a joy for me. I like encounters with people who are going to be doing this job a lot longer than I am.
And it's an understatement to say how important and needed it is now, and it's going to be, as they say, the genie's not going back into the bottle.
That is
On
for sure.
a little bit a different note, I think we have a few minutes here, so we're good. There's a concern that telemedicine disadvantages, and you alluded to this, some patient populations in the same way that remote learning disadvantages some student populations. What are some ways we can overcome that?
Well, I think we can elevate it from a concern to a reality and then take responsibility for addressing those issues directly. Um, um, we have been working hard to gather the funds to buy a bunch of gizmos. So we have a stack of about 60 data-enabled tablets that we use for folks. We don't allow it to be a barrier for them to receive palliative care. And so we ship them around, we lose a few, we get a few stepped on or rolled over by wheelchairs, and one or two have been kind of lost the follow-up. But at the end of the day, as an investment in connection to people who need us, it's a very modest investment. The other group of people that we work really hard to program, and we're only now beginning to sort of make progress after 4 or 5 years of purposeful effort, of Native American populations. They're the communities of greatest need in our sort of central headquarter geography. Those are the folks that are sort of front of mind. But also, there's a group of people that have been living and dying just out of sight of most of us in the elderly, skilled nursing facilities, and long-term care environments. And these folks we've not broken through, and the biggest barriers are economic, related to how Medicare currently, but hopefully not forever, thinks about value-based payment as it relates to really sick people. Those are the groups that are most front of mind for me. The Native American communities, because I live amongst them and I live on their land, and the folks that hide in the shadows in the nursing homes who small things could make a big difference for them and their families. One of the things that we're working on, and I've seen it done successfully nationally, is that because nursing homes are so tight with resources, so thin on margin, and so protected from infection control, trying to break through and give ways of being able to put tablets into the room of people who are sick and connect them with others. There are programs happening around the country that are doing that most effectively. We haven't made much progress in that regard, but we're trying.
Good goal. Good goal. We have time for another question. And let me see if the ones.
I like quiet walks on the beach under the moonlight. I'm a Virgo, but a disorganized one. No, bring your question. I'm just kidding.
Okay. Evaluation criteria. Let's talk just a couple minutes about that. Should different evaluation criteria be used to assess the effectiveness of remote learning or remote patient visits versus inpatient? And what criteria would be different? Maybe this is around value-based.
No difference at all. No difference at all. This is caring. This is healthcare delivery. The goals are the same: improving the quality of life, improving the satisfaction, improving the sustainability of the work for those of us doing the work. The metrics are exactly the same. The National Quality Forum, 4th edition, are just as good if you've got a bricks and mortar clinic embedded in a cancer program or a primary care program or your own freestanding palliative care clinic or the hospital bed. It's the same. We've got to let people know that we care for them and that we have fundamental tools, technical ability to provide them with a greater quality of life for as many days as they are meant to live. So no, there's no difference at all in how you assess quality doing telemedicine. I think there's some advantages to doing some things in person. There's some substantial advantages to doing some things by video conferencing. I do that a lot, I know.
And it helps remind us that it is the window. It is the window to the people that we care about, the people we care for. So we have just a couple minutes. What parting wisdom would you share with us?
It's not about the technology, people. It's not about the technology. It's about showing up for people as the people that they are, the way that they see themselves. And it's showing up to them as the person you are. We've all worked hard to learn what we need to learn to get our little credentials and our licenses and everything else. But at least in the palliative care space, that's not what's most important. It's not about what's the matter with people. It's about what matters to them and really, really being curious, really, really learning to lean in. Whether you're seeing them in person, whether you're seeing them by video, whether you're seeing them projected onto the side of a building, doesn't matter. It's all about showing up for people who really deserve to have someone show up for them.
Wise words. Wise words. Thank you for your presence with us. Thank you for the work that you do. Thank you for your reach really across the country in what you're sharing with us, and appreciate it. I know our audience appreciates it, and thank you.
Oh, thank you, Pam. It's a pleasure. Thanks for the opportunity to speak to people, even though I can't see them. They're going to see me, but I can't see them. Next time, we'll do it at the same time.
And we look forward to doing that in 2021. So I hope you'll join us then.
For
Thanks so
sure.
much.
For sure. Thank you.
Stay safe. That was wonderful. Now we have an opportunity to take a 10-minute break, and then we'll come back for our Symposium Spotlight topic presenters.